Okay, so thank you very much for having me here. It's really amazing to see so many people come together, and I love the fact I'm a big, believer in patient advocacy, and so taking patient advocacy to DC is just at the next level. It's really amazing, and I've been tasked to talk specifically about ocular surface pain, so I'm not going to talk that much about other therapies, but I will be here all day. So if anyone wants to come and find me and ask questions, I would love that. My disclosures have already been mentioned, but I do consult for several dry eye companies, and I receive grant funding from many agencies to study ocular pain. And so what do we know? What we've heard today is that many patients feel their eyes in an unpleasant way, and that is what I am calling ocular pain. And that doesn't mean that everyone experiences pain in the same way. Many patients use the word dry, but there are other descriptors that are often used, and pain can be experienced at the level of the eye, behind the eye, on the upper eyelid, radiating. And so when I use the word ocular pain, it's whatever your pain experience may be, and it's important to realize that it's different for different people. The big question is, when someone comes to me and they have ocular pain, what does that mean? And the reason I ask that is because when I do get to the slit lamp and I look, everyone looks a little different. And so for me, if there's one take home that I hope you have, is that feeling your eyes or ocular pain can be caused by many things. And that's why I don't like to just stop and say dry eye. I want to say why. Okay, there are different symptoms. People look different when I see them. And that is because I think people have different contributors driving their pain, and people need different treatments depending on their contributors. So the entire goal is to find the individual contributors and target them. But there is a unifying theme, is when you feel your eyes or you feel anything, it's because nerves are firing. And there's a whole plexus of nerves that connect the eye to the brain and the brain back to the eye. And I see myself a little bit of a detective, right? I want to understand why the nerves are firing. But a bigger question is not just why, but which nerve is firing. Could be one, could be all of the above. So I want to talk a little bit about the pain experience. And the pain experience is really complex. And this is why it's not about what we see, because it starts with what's in the environment and what we see on the ocular surface. But then we have a series of peripheral nerves that take that information and process it. Then we have a series of central nerves that take that information and process it. Then we have a series of nerves that go back from the brain to the eye. And when we're talking about the pain experience, it's 1 + 2 + 3 and maybe +4, right? And so if I experience something and you experience something, it's not just about what's happening at the level of the eye, it's about the processing that takes place. And so as a neuroscientist, and that's why I love talking to Deb, she's actually a neuroscientist, the final outcome of what you feel comes from the brain. It may start at the level of the environment, but it ends in the brain. And so we just can't stop by just looking at what we see. We have to think about that whole process. But let's start with number one. The punchline is that anything in the environment or on the ocular surface can lead to pain. And we call that nociceptive pain because it means that there's something that we see that is triggering the nerves. And there are so many causes of nociceptive pain. So my exam, like everyone else's, starts from across the room. I'm looking at the skin. I'm looking at the blink rate. I'm looking for exposure. I ask patients to close their eyes to see if they can close their eyes properly. I finally get to the slit lamp, and I'm looking for evidence of anterior blepharitis, which itself can be caused by many things. This is an example of Demodex. I'm looking at the eyelid margin, looking for evidence of inflammation. I'm looking at the health of the meibomian glands, the quality of the meibum. I put some staining in so I can look at anatomy. Then I look for tear stability. Then I look to see if there's scratchiness on the ocular surface. Then I look for health of different aspects of the eye. For example, this is an example of unhealthy limbal stem cells. I am a big fan of Schirmer strips. I stick them in and I want to look for tear production. And then I ask patients about their environment. Are there air pollutants? Were you just in forest fires? Is someone painting your house? Do you have allergies? There's so many things that can be in the environment that can affect the eye. And the punchline is this is pretty busy. This is my routine exam. Everyone gets this. And the idea is I treat what I see. And beyond just looking at what I see, the reason I think a history is so important, because what I have learned is that the way people describe their pain can also be a clue. So I have found that if someone uses the word gritty, that is generally nociceptive sources of pain. I can usually find something on their ocular surface that I can attribute to pain. And so, for example, when I look for laxity in the eyelids, and the eyelids are flipping over at night and rubbing on the pillow, many people describe that sensation as gritty. Same thing for itchy. Now, itchy can mean many things, but I always look for things like Demodex or allergy when I hear the word itchy. But I never forget that looking at the ocular surface isn't enough. And then I have to think about the nerves that connect the ocular surface to the brain. And sometimes we forget that nerves are living, breathing beings, and nerve function is not identical. So I've done this before, but I'm not going to do it today. I've given everyone a toothpick, and I asked you to poke the hand of the person sitting next to you. It's a good way to kind of break the ice. And then you're going to ask the person next to you, hey, rate the pain from a scale of 0 to 10. The same poke is going to elicit a different pain report, right? Same input, different output. Now, if you look at people as a group, women tend to rate pain higher than men. Young people tend to rate pain higher than old people. But really, everyone is an individual and have their own nervous system that interprets what's happening in their environment. And the punchline is that nerves sometimes are abnormal. They can be too sensitive or not sensitive enough. And when nerve dysfunction drives eye pain, I call it neuropathic or nociplastic ocular pain. And that's because ophthalmologists love fancy terms. But let me break it down to you. Neuropathic means that there's a lesion or disease in the nerves causing pain. So if someone has pain right after surgery, I know nerves have been disrupted. If someone's had a viral infection, I know that affects nerves. I call it neuropathic. And if the nerves become abnormal just because I just can't find a lesion or disease, it doesn't mean it doesn't exist, I just can't find it, then I call it nociplastic. And there are other pain conditions that are thought to occur secondary to nociplastic mechanisms, like fibromyalgia and migraine. And the literature is really confusing because there are a lot of different terms to get at this idea that nerves are abnormal. I like NOP because it's like I don't know where the problem is, I don't know if it's neuropathic or nociplastic. It's kind of an agnostic term. But the punchline is all of these terms mean that the nerves aren't normal. And so to me, that's my dichotomy. Are the nerves normal or are they not normal? And so what are the clues that I use to tell me that nerves aren't normal? In animal models, we stick little needles in nerves and look at function. We don't do that in humans. But I think we have some good clues that are cheap that anyone can do to try to help us figure out when there is a nerve abnormality, okay? So the number one, this is the most important one, is history. I'm looking for pain that started after surgery or after a viral infection or someone who has migraine or fibromyalgia. Again, these are just clues. I'm looking for symptoms that are out of proportion to signs. It doesn't mean there are no signs. I can find some sign in everyone, but it's just out of proportion. I'm looking for certain symptoms, and we're going to talk a little more about that. And then I'm looking for pain that persists despite me treating what I see. And those are my clues to say, hey, I think nerve abnormalities may be driving your pain. So this, and we've talked a little bit about this, the reason people get stuck is because I usually can find something in everyone. But just because you see something doesn't mean it's causing pain. Low Schirmers in itself do not cause pain. It's how your nerves interpret the low Schirmers. So it's important to treat what we see, but to move on when we need to. So what are we going to be talking about? How do you figure out, in humans, which nerve is abnormal and what to do about it? So let's start with the peripheral nerves. The peripheral nerves are the nerves at the level of the ocular surface. The cornea is densely innervated. I don't know if any of you have ever had a corneal abrasion. It really hurts. And the job of nerves are to sample what's in the environment and send information to the brain. And there are different types of nerves that sample the environment. Some sample being poked. Some sample a variety of stimuli. Some sample evaporation. And we still don't know whether different nerves are abnormal in different patients, but we do know that these nerves have little channels on them, little proteins that companies are now trying to manipulate to see if they can change the pain experience. And so there is a TRPV1 antagonist trying to block TRPV1. There's a TRPM8 agonist trying to activate it, and we still don't know how that's going to affect our pain, but we know that this is something that is being investigated. So what are the clues that corneal nerves are not okay? What I look for are specific symptoms like burning, shooting. These are called neuropathic pain symptoms, validated for neuropathic pain in other sites and probably relevant to eye pain as well. The next thing I do is I like to test for function because just like Deb, I believe in function more than anatomy. And I use a Q-tip. Some people use dental floss. And then there's some fancy machines that are out there that can give us a more quantitative idea. But what I'm really looking for is abnormal. So is it not enough or is it too much? And different pain populations may have different abnormalities. So people who have pain after refractive surgery, they oftentimes have decreased sensation. People who have pain in the setting of migraine and fibromyalgia, they oftentimes have increased sensation. So for me, it's not just about, it is about decreased or increased, but the bigger punchline is it normal or abnormal? Pedram Hamra, who's one of our colleagues and is really a pioneer in this field, he looks at nerve anatomy, and what he has shown is that maybe there is a marker of peripheral nerve abnormalities in what he calls microneuromas, where the nerves stop and they're hyperreflective. There's still some discussion on how to interpret this. It's certainly out there, and I think the confocal images probably tell us something, but we just need more data to try to understand how to best use them. But the punchline is burning, pain that started after a peripheral nerve injury, abnormal corneal sensitivity, and maybe some changes on confocal microscope make me think that corneal nerves may be abnormal. But we can't just stop at the cornea. We have to think about the brain. And there are certain clues that I use to help me figure out that maybe the brain is on fire. I'm looking for specific symptoms like light sensitivity. I'm looking for pain that extends beyond the eye. I'm looking for comorbid headache. And then, again, not expensive, every eye doctor can do this, I use my anesthetic challenge for function. I ask people to rate their pain. I put a drop of anesthetic. I ask them to re-rate their pain. If the pain is mostly gone, then I think this is either nociceptive or a corneal ocular surface nerve problem. If the pain persists, then I think it could be the brain or it could be another part of the body other than the eye, like dental pain that's referred. And so to me, this is a really important test. The other very inexpensive test is to slightly touch the area around the eye. And if people have hypersensitivity around the eye, again, that suggests that the problem is extending beyond just the ocular surface. And the punchline is that in some people, abnormalities at the level of the brain can contribute to ocular pain. And again, I'm looking for light evoked pain, pain elsewhere, and persistent pain after a topical anesthetic. A newer topic, still controversial, is the role of autonomic nerves. And we don't really know how they affect ocular pain, but I can tell you that in certain subtypes, dysautonomia symptoms are common, especially in my autoimmune dry eye population. There's a questionnaire, it's called the Compass 31. It asks 31 questions about different aspects of autonomic symptoms. And what I have found in my patients is that about 3/4 of my patients who have autoimmune dry eye, they also have dysautonomia symptoms. The question, though, is why am I telling you all this? Like, why does it matter what causes ocular pain? Hopefully you already know the answer, but it's because plan A is always to address what you see. And it could be inflammation, it could be meibomian glands, it could be Demodex, it could be rosacea, different things in different patients. But the punchline is, in life and ophthalmology, if plan A doesn't work, you need to have a plan B. And plan B, if you think there are nerve abnormalities, it's important to address them. And so the bigger question is, how do we address nerve abnormalities? And obviously, the problem is there are many, many different ways to address nerve abnormalities. So again, we have to be specific and we have to say, I need to address the nerve abnormalities at the level that they're abnormal. So if corneal nerves are thought to be involved, we oftentimes use blood products, and they have autologous urine tears, PRP, PRGF. We don't know which one is best in which patient, but that is my go-to, and Pedram has shown nice data that in some patients, blood products help in patients who have corneal nerve problems. This is the type of problem the companies are really excited about, because again, if the nerves are a problem at the level of the eye, that it could be that eye drops are the ones that can help modulate corneal nerves. And so Pedram was doing a study that was just recently stopped, but hopefully we will restart it if the data are promising. And so I think we will hear more and more about eye drops that will be investigated to treat patients with corneal abnormalities. But not everyone has corneal nerve abnormalities. Sometimes it's central. And once I think there's a central problem, that's when I really like oral neuromodulators. These are not pain meds. These just change the function of the nerves and turn down the gain. There are many, many different combinations. I have found sometimes that cocktails of a few of these at low doses are better tolerated than one at a high dose. And again, there are many different strategies, and I've had all of them work in some patients and not others. So again, it's about really finding the individual approach. But the big mantra is start at a low dose, titrate up slowly, and give it time. To me, neuromodulation is like watching paint dry, and it takes 3 to 6 months to see an effect. Now, when I think that the peripheral nerves around the eye are a problem, and I do that by trying to see if there's sensitivity to light touch, or in patients whose pain started after surgery, I do have a wonderful pain specialist who likes to stick needles in things. That's what pain specialists like to do. And he does diagnostic blocks on the periocular nerves. And if the pain gets better, then he sometimes does therapeutic blocks. He adds some corticosteroids or radiofrequency ablation. The problem is this isn't right for everyone. It's right for a certain subpopulation that we're still trying to figure out. But to me, it's about finding the right therapy for the right patient. Some of my patients have a migraine-like phenotype. Doesn't mean they have migraine, but it means they have light sensitivity. The pain started spontaneously. Maybe they have a family history of migraine or a history of headache. And there I use therapies that have been approved for chronic migraine. I like trigeminal nerve stimulation. This is an over-the-counter device that's been approved for that in the US. And I like botulinum toxin because it's been approved for chronic migraine. And I like tints that are often used in migraine. And sometimes people ask me, like, are you really doing anything, or do people just like that you get rid of their wrinkles with Botox? And I think that's a legitimate question. I think all questions are legitimate, and that's why I do a lot of research. And so one of the programs we have is an fMRI program where we stick people in an fMRI machine and we have them look at a white screen to stimulate light. And we did that before and after Botox. And what we found that 6 weeks after Botox, we were able to decrease activation in parts of the brain that deal with pain processing. And I found similar things when we did the same studies using tints. So I do think that strategies that are targeting migraine mechanisms do affect ocular pain in the right patients. Okay, I still don't know what to do in patients with autonomic dysfunction, and I still don't know how to best address the emotional component that we heard about that goes with chronic pain. But what I do know is addressing the emotional component is so important, and it helps in other pain states. So they did a study in chronic migraine. Everyone got amitriptyline, which is one of the many neuromodulators we use. Half got cognitive behavioral therapy. It was pretty much coping with chronic pain, half didn't. And the people who got both a medical therapy and CBT, they had less headache days because, again, pain output comes from the brain, and just dealing with CNS, the emotional component, helps with processing. So we don't have any studies specifically on central abnormalities in eye pain, but the key is always active coping mechanisms, finding a way to live with your pain, versus passive coping mechanisms, stop what you're doing, sit in a dark room, don't talk to anyone. So how do we get there? Well, there are formal programs. We've heard a little bit about meditation. Some people don't like to meditate. Some people like exercise. All these different things have worked, but they work differently for different people. So it's just about knowing that it's an important component, but you have to find the thing that resonates for you. So what is the punchline? Hopefully I didn't just overwhelm you with so many details. This is an evolving field. I don't have all the answers on the best way to diagnose and manage ocular pain. I don't have all the answers on the best way to diagnose and manage dry eye. But it is really nice to know that there are so many clinicians and patients that want to improve things for everyone. And so I do think that there are lots of ways to treat, and we will get better, and we will get more data so we can give better information. But the reality I tell my patients is it's often not one thing. It's multimodal therapy, and the goal is Goldilocks. Not too little, not too much. Patience is really key, though. Once you're dealing with nerve abnormalities, neuromodulation takes time. And until we find a better and faster way to neuromodulate, I think just understanding expectations is really important. But my mantra is never give up. I think that's your mantra after I've heard your amazing presentations, because there's so many things we can do. And I think it's really about just trying different things to get to the goal of good enough so we can live your life in the best way you can. And so I'd be happy to take questions later. Thank you for having me here.
Thank you. I'm not quite sure what I've done wrong, but somehow we're slightly ahead of schedule. My bad. So I have one question I would like to put out there, and then we'll have Dr. Chu, and then I think we'll open it up to questions for all the speakers. I just want to go to something, 24 slides or so ago. Function versus anatomy, and you mentioned that Dr. Jacobs talked about that as well. Can you somehow break this down to third grade language for me?
Yeah. Understanding anatomy is the basis of what we would call Western medical care, meaning doctors are taught what the structures of the body are and when they're normal or what's typical. And we're taught that usually disease process ultimately changes anatomy. That's what pathology is, when you can look at a piece you've taken out or after someone's died and see the change in that organ. As time went on, we got better at recognizing, well, pathology you can also recognize when there's something visibly wrong with the body. You can use a microscope to help, or other machines, or slit lamp, or a stethoscope. And the construct of understanding disease in Western medicine is that there's a disease process, a scientifically characterized process that ultimately changes the structures of the body and may or may not cause symptoms, and that's what a disease is. The problem is that not every disease or organ system has things that can be seen. They don't have structural changes. And when structure and function match, then we feel very good. We know what we're seeing, we know what we're treating, we look for that structural change not to happen or get better. But there are many disease processes where there's no structural correlate to the functional change. Like even diabetes, what do you want me to do? Oh, the static. All right, sorry. Wait. Yeah, so diabetes has no structural change, but the functional change is that there's damage to end organs. We learned how to measure if we were headed that way by looking at blood sugar and hemoglobin A1C. So we like it when the structure and the function match. Where we get hung up is when there isn't a correlation. So there can be structural changes that don't manifest as disease, or there can be disease that has no structural changes. And I think in some ways the meibomian gland issue falls in that category. We know it's a structure, and we know when it's distinctly abnormal and it correlates with a disease. But we don't know the continuum in the middle and how it accounts for symptoms. Did I make that more confusing?
No, and migraine's the other one. And so migraine, people have a functional issue, but when we do an MRI, it looks okay. And so there are diseases where you see something and it matches what people are telling you, and there are diseases where it doesn't. And that's just reality. And oftentimes, pain can do both. Pain could be due to something structural, nociceptive, or it could be due to nerve abnormalities. And so we just have to be okay understanding that it's not always going to be nociceptive, and sometimes people have pain and we're not going to see the answer it doesn't mean there's not an abnormality. And I think ophthalmologists are very visual. Most of the times for other diseases, we look and we're like, okay, we don't need to talk to the patient because the answer is right there. This particular field is one where that's not the case. It's hard for ophthalmologists to deal with that.
Yeah, I would say that's true. Like dermatologists, for the most part, deal with structural things. But there is a field of itch and pain within dermatology, and it overlaps with our field, where it's more the symptoms, and we have to think differently about that. Yeah, I would add that. Neurology, they do love the structure. Take the CAT scan or the MRI, explain the problem. But there are many neurologic problems that don't have a structural correlate.
All right, thank you so much.